So contraception for you is very important regarding the percentages they are asking, and I am not going in detail in contraception. I mean not every point. So whatever the previous asked questions for you, so I made it in the form of whatever the bits. So I'll teach you what are all the important things in contraception. Because once you start reading the contraception, there are many things to remember, but no other alternative. Because every year there are some questions regarding this contraception. Any method, it can be the simple methods like coitus interruptus, starting going for higher things like implant. So anyway, they are asking questions in contraception. So I'll tell you whatever the frequently asked questions and very important questions for you. Okay, I'm covering almost all the parts in the contraception. It will take around 2 hours for you only regarding the contraception, because many questions are there. Something around, we can frame 200 questions only from this chapter. So totally we can frame 200 questions. Even 2 to 3 questions are asked at a time in single exams, either for you APPG or whatever all India or AIMS. One question will be from contraception definitely. 1 to 2 questions you are getting, minimum 2 to 2 questions you are getting. So contraception is very important for you. Any either DNB, whatever the exam you want to give. So coming to the next method, the mucus method, otherwise called as billing method. So remember these names. So previously we have discussed. So normally under estrogen, what it is going to happen, the mucus increases or decreases? Increases. So in quantity also it is going to increase, and it will be more slippery. That's what we told you. So it will be more slippery, something like a rubber. It will stretch and it will not break easily. So and elastic. Whereas under the influence of the progesterone, mucus becomes thick, scanty and dry. And why this is not unsafe? I mean why this period is safe? Because this whatever the thick, dry, scanty mucus, it will not allow the sperms. Whereas the cervical estrogen mucus, it is fertile mucus, we call it as. It whatever the slippery thing, it will allow easily the entry of the sperms. So intercourse is considered safe only during the dry days. And suppose a patient want to do want to maintain contraception only basing on this method. So how do you advise a patient? Suppose tell the patient whenever she feels wet. I think I'll show you the slide you are having. This is the typical thing. So the early mucus, when you start, suppose immediately after the periods, it will be like this, slight amount, thick, white, sticky something. Whereas in between it is like this. It will be slightly stretchy. This is the typical highly fertile mucus. So when you put in between your fingers and stretch it like this, the mucus will stretch and it is thin, transparent. This is called as fertile mucus because of estrogen. So the patient, whenever she feels such a fertile mucus, always ask her to have not to have a intercourse. So how many days she should not have an intercourse? So she will have whenever during the ovulation period and all, these secretions will be there. Lot of secretions, because we already discussed. In progesterone there will be scanty, whereas in a case of estrogen there will be lot of secretions. So even after 3 days she feels wet. So once the ovulation is finished, the whatever the estrogen secretion is diminished, the cervical secretions also decrease. So she should maintain not to have an intercourse until 3 days after the wet days. Suppose today she felt wet, tomorrow she is not feeling wet, but even 3 days she should not have an intercourse. Is it clear? So temperature method. One more thing is, why this basal body temperature, how much it is going to increase? 0.5 to 1 degree or centigrade Fahrenheit, which one? 0.5 to 1 degree Fahrenheit. It is why the increase in temperature is due to which hormone? Which hormone? In which phase? Still the chart is here. It is due to which hormone? The increase in progesterone. The increase in temperature is due to progesterone. So the hormone which is causing increase in temperature is progesterone. So remember this, the progesterone is having a thermogenic effect on the body. That's why the patient will be having a increase, she feels the day of temperature shift. It indicates time of ovulation. So this is nothing but okay. Just ask the patient to have an abstinence till 3 days. Even she feels today very hot. Later even 3 days ask her not to have an intercourse. Coming to symptothermal method. Symptothermal method. This is what he was answering. So the symptothermal method is an integrated method. Name is not integrated method. We use a combination of all these procedures. That is called a symptothermal. So what are all the things we are using? We use calendar method, We use cervical mucus billing method. First, initially we start with calendar method, like how we calculate the calendar method. We ask the patient, we calculate the safe period by using calendar method. But at the end, we end by using cervical mucus method. Okay, at the end, when to stop the safe period, we decide it by basing on the cervical mucus. So it is mixture of the all the methods, and even basal body temperature can also be used. So this is the basal body temperature we can see. So prior to, so there are 3 days. So suppose the 14th day is the day of ovulation. After the patient feels something. So after 3 days, until after this, the patient should not have an intercourse. But later that, it is all considered as safe days as per the basal method. But prior to these 3 days, it is not recorded. I mean, there is no study indicating whether it is safe or not. How many days prior to that it is safe. But after this maximum rise of temperature, once the temperature comes down, these are considered as safe days. Here we can see this is safe days. This is calendar method or this is the menstruation we can see here. These are all 5 days normally unsafe. Suppose if we do this 14th day of ovulation, we have discussed 12th to 16th day, we may assume ovulation can occur at any time. So normally 14th day means we will consider 5 days here, 3 days behind. Is it clear? One more method is withdrawal method. It is nothing but coitus interruptus. We call it as coitus interruptus. What they'll do? They'll ejaculate outside. Suppose just before ejaculation, the husband will ejaculate outside. But still the failure rate is very high. Why? Even though he is ejaculating outside, why the failure rate is very high? Because it's not only the semen which is very important. Initially, during intercourse, initially there will be prostatic secretions. These prostatic secretions contains high amount of spermatozoa. So even though they don't ejaculate inside, but because of this prostatic secretions, whatever the fluid is secreted, it is secreted prior to ejaculation, even it contains spermatozoa. So it can transmit to the female, causing high failure rate. So coitus interruptus has got a 25 failure rate. So which was previous 25? Now beneath that, right, coitus interruptus 25 per 100 women years. So in perpurium period, why do you think the woman will not lactate, will not become pregnant? She has given birth to a baby, but still they may have intercourse, but still she will not become pregnant. So for how many months she will be protected like this? 3 to weeks or months. If it is for 6 months, then why you give copper D for 6 weeks after delivery? So there is difference. Normally regular breastfeeding, every 4th hourly she should feed the baby. So if the mother is able to feed like that, then only it is protective. Suppose the mother is not feeding the baby, so there is no use. Why? Because this inhibition is mainly because of this prolactin. Prolactin is going to inhibit directly, okay? GnRH, FSH, LH and all. That's why there will be decreased ovulation. That's why a breastfeeding woman cannot become pregnant. But she should regularly breastfeed the baby. Then only there will be useful. If she is not regularly breastfeeding, she can conceive at any point of time. Failure rate. Now write for breastfeeding. What is the failure rate? So if a patient is regularly breastfeeding as per the whatever we have told, every 4th hourly, the failure rate is very, very low. So that's why most of the breastfeeding women, they don't become pregnant. The failure rate is 0.5 to 1%. And why it is only for, normally you can see in any breastfeeding woman, she will not become pregnant for approximately 4 to 6 months. After that she will become pregnant. Why? Normally the breastfeeding will give it for 6 months to the baby. So the 6 months the prolactin is secreted. Later that automatically the prolactin levels decreases. So once the prolactin decreases, the suppression on GnRH, FSH, LH decreases. Finally, once again stimulating the ovulation. Is it clear? Yeah, coming to barrier method. What are all the barrier methods? So these are all the natural methods we have finished. Natural methods you know. So what is the failure rate? What are all the various methods we have discussed? Fast, anyone? Billing method. Next. Otherwise called as billing method, otherwise called as cervical mucus method. Next. Fast, natural methods. Calendar method, otherwise called as. Next, otherwise called as. Next, other methods. Coitus interruptus, breastfeeding, basal body temperature, symptothermal method. So, why I am asking you? They have asked which of the following is not a natural method. So, you should know which is a natural, which is a barrier, which is a IUCD. So, this is all the natural methods. Now, we are entering into the barrier methods, the second topic. So, first, the most common, what are all the barrier methods you know? What are all barrier methods you know? Fast. Condoms, good. Next. Diaphragms, next. Okay, spermicidal agents, good. Next. Only condoms and today, yeah, that is sponge. Next. Female, what do we call it as? Diaphragms, cups, everything. So, coming to barrier method. So, normally barrier method, most commonly male condoms. First thing we read about is male condoms. Remember, they are made up, there are latex condoms and non-latex condoms. But they are made up of polyurethane. Remember this, they are made up of polyurethane. So, there is something polyethylene, we will see where polyethylene will come. So, these condoms mostly they are made up of polyurethane. So, most common side effect with this condom is, what is the most common side effect with this condom? What is the most, this was asked, Ames question, what is the most common side effect with condom? Why condom most people will prefer, but what is the most common side effect if they use it? Yes, good, it is nothing but simple but irritation, it causes irritation, vaginal irritation and all, that is the most common side effect. That's why we are going for nowadays non-latex polyurethane condoms. So, how, there are two types, one is latex condoms and non-latex condoms. So, other important point you have to remember is, these condoms they are going to prevent HIV infection such as HIV. So, condoms other advantage is not only contraceptive methods, we are also able to prevent HIV. So, latex condoms prevent STDs such as HIV. Whereas, regarding herpes and all, condom, where is the condom it is? There are other methods, various other methods I will tell you in the females also, diaphragm method and all. So, in such a cases also the chances of herpes and all is high. Okay, we will discuss that in next slide. Remember that condoms can also prevent STDs. Okay, that is the point you need to remember. This is the male condom. Here you can see. So, this is something like a rubber sheet placed over the erect penis. So, when to place it? Over there, yeah. What's her name? You, what's her name? Rubina. That day I told I'll give, I forgot, now I remember. Give a clap to her. She has answered which question? She has answered which question? What is the answer? Very good. Subnuclear evacuation. Where do we see it? During ovulation period. It is the histological. Come here. I think it is bit wet. You have to put it in deep fridge. Rubina, clap. Why are you so jealous? Claps. Yeah, continue our class. Yeah, Bhakti, you are right. It causes irritation. So, it is the sperm barrier that prevents semen from entering the vagina. So, a question was asked like this. So, how do you, before applying the condom, important thing is, it should be applied, which of the following is true about the condom? This was asked in Ames question. So, it applied over the erect just before, it should be applied just before ejaculation. Second thing is over the erect penis. Third thing is, we should never check the condom whether it is working or not by inflating and deflating it. Always remember, okay? Never check the condom by inflating and deflating it. Third thing is, you can, whatever the air, you can, are you able to see the tip? The condom is having some tip here. Is it clear? This tip. Always try to press the tip so that whatever air is there, it will come out. So, that is the important points you need to remember about the condom. Confusion or clear? Confusion or clear? So simple. Apply it. When to apply the condom? Just before ejaculation. First thing. Second thing is over the erect penis. Third thing is, don't inflate it. Try to inflate it. Okay. That is the question which was asked for you. Third thing is, whatever the air is there at the tip, we need to push out the air. Okay. Yeah, anyway, I put the question. Yeah, tell me which is not a correct statement regarding condom. B, it should never be tested by inflating. So air should be squeezed out of the tip, put it on the erect penis, and can we apply KV gel? KY gel? What is this KY jelly? It's nothing but a spermicidal jelly. We use this jelly to kill the sperms, whatever the sperms are there. So this KY jelly can also be used along with the condoms to increase the success rate of contraception, but never tested by inflation. This was Ames bit for you. So these are all the various condoms, cups and all. Yeah, coming most commonly India supplies Nirod band. So we are not worried about it. Write about pregnancy rate. Condom. Beneath the coitus interruptus. What was the failure rate? Above that, what was the failure rate? Calendar method. Failure rate is approximately. So now beneath that, write condom. The failure rate is, so half of that, 10 to 14. Okay, per 100 women years. Without seeing the slide, tell me, where else we use condom other than contraception? So what are all the other uses of condom without seeing it other than contraception? Huh? STDs, very good. Just now we have discussed to prevent STDs. Next, where else we use condom? Condom catheters for. One more important thing is condom important usage is after vasectomy. So even though if we do vasectomy, the next day or immediately next week itself, the patient will not be sterile. Okay, there will be still the spermatozoa will be secreted. The very important thing is the next class we will discuss regarding the vasectomy and tubectomy. Important point to advise the male partner is immediately after the vasectomy he will never be sterile. So what you are going to do, you ask the patient to go for barrier method for 12 ejaculations by using a condom. So that is where the other alternative we use. And second thing is even in immunological infertility. Where do we see immunological infertility? Anti-sperm antibodies. So where is the anti-sperm antibody? Cervix. What is the treatment for that? Suppose female patient with anti-sperm antibody, in infertility couple with anti-sperm antibody treatment. Intrauterine insemination, you are crossing the cervix and directly putting it in the uterus. That is intrauterine insemination. The test how you detect is? Otherwise called as fast. Otherwise, Hanna's test, Sims test or postcoital test. Manne kada class winner, infertility, very important class for you. So other than that, cervical mucus, normally what are all the typical features of Sims test? Normally what should be their findings? How many spermatozoa? 10 to 15 spermatozoa per hyperfield. Next, what are all the things you are going to see? Which movement? Forward movement, not rotatory movement. Always forward progressive movement, not rotatory movement. So these are all the things which you are going to see. Yeah. So important other uses of condom is following vasectomy we use it for 12 ejaculations. Next for immunological infertility also. Next to prevent transmission of other infections, whatever we have discussed, some HIV and other infections also we can prevent it. Coming to spermicidal agents. Spermicidal agents normally they contain, this was asked for you. So which of the following is a spermicidal agent or which of the following is not a spermicidal agent? So there are three important spermicidal agents. What are those three? Can any one of you tell me? Nanoxynol 9. So three important are octozinol and menfezol and nanoxynol 9. Write these three. I mean anyway you are having in your notes, don't write everything. It is given in your notes, okay. So the three important spermicidal. So which of the following are the spermicidal agents? These three are the spermicidal agents. Failure rate, right beneath the previous thing. Failure rate is 30 per 100 women years, okay. But spermicidal agents were never asked as a failure rate. This is the rare question. They are never asked. I never heard or never seen regarding the spermicidal agent. And it remains effective for 1 to 2 hours after the application. So whenever you apply, it can remain effective for 1 to 2 hours. Ashwin, notes. I think you got, all people got notes. Notes is with you, no? Notes ichara villaki andarki. They are asking for notes. Ashwin, which area? Ashwin, let me know which area you belong to. So spermicidal, this is the spermicidal agent, whatever the jelly, it can occur either in the form of available in foam, jelly, whatever the forms. So we are injecting with an applicator. Priorly it is inserted into the vagina before intercourse. Before intercourse you are applying it with an applicator. So whatever the chemicals, the important thing is how does it destroy? The question was asked for you in names. So you have given spermicidal jelly. How it is going to kill the sperm? By which mechanism? Disruption of, very good, it is acting on the surface active agent. It acts as a surface active agent and it is going to destroy the cell membrane of the sperm. So this was asked in AIMS. So how it is going to destroy the sperm? So it acts on the cell surface as a surface active agent and it is going to destroy the cell membrane of the sperm. So that's how it kills the sperms. And one more, this is the point I want to tell you. So in a case of HIV patients and all, it causes sometimes irritations. Previously I told you the most common side effect is irritation and all. So in chronic use, if you are going to use chronically, it can cause vaginal ulceration. So if the female develops vaginal ulceration, further you are going to increase the risk of HIV infection rather than prevent it. So in a patient with HIV couple, never advise a spermicidal jelly. Is it clear? You can go for condoms but not condom with spermicidal jelly because this can cause more irritation, ulceration, and further it can increase the transmission of the HIV. And recent some new that is in the HIV patients, it was antiviral tenofovir, new spermicidal cream. It's still under study. It's not under, it's not given under your books. You can leave this. So it contains surface active agents that damage the sperm cell membranes. This is the mechanism of action. Yeah, tell me. Now we are going to male, we have finished, we are going to female. What are all the female barrier methods? Diaphragm, sponge, cups. So coming to all that methods, now we will discuss regarding the female methods. So which female method we can't use it? Or all are contraindications except? All are contraindications for diaphragm except. Can we use it in prolapse? Why? Patient with prolapse, if you put diaphragm inside, what it is going to happen? It will prolapse, it will not sit in the position. The prolapse is already coming out. So if you put, it will still come out, it won't sit. So prolapse is not the answer. Then recurrent UTI can we give? Multiple partners? So we will, regarding contraindications and indications are very important in contraceptive chapter. Either for IUCDs or this methods, they are very recently, around 10 questions are there regarding only regarding indications and contraindications. I will first tell you that discussion, then we can answer this bit easily. So coming to diaphragms, we are in the diaphragms. Diaphragm is mostly used for a female, nothing like a female contraceptive. So what is diaphragm normally? This diaphragm we can apply spermicidal jelly and we can insert it easily into the female, that is diaphragm. And important thing is you need to leave the diaphragm for 8 hours after the intercourse. Okay, whenever you apply before the intercourse, you have to leave the diaphragm and all for 8 hours after the intercourse. It will work like that. So if you, even after the diaphragm, if you immediately remove after the intercourse, it is not going to work. So you have to leave for a minimum of 8 hours after the coitus. And important, no douching and no discomfort and all. So this is the diaphragm. We have put here the diaphragm. You can put directly into this. There are various types of the diaphragm. In the next slides we can see. Leave this diaphragm for 8 hours after the intercourse. So this is the jelly. We are putting contraceptive gel, spermicidal jelly, and this is the diaphragm, and insert it like this. It is otherwise called as Dutch cap. So Dutch cap otherwise called as diaphragm. So normally we put it obliquely into the vagina. It normally sits from the pubic symphysis to the posterior fornix, so that it will cover something like a cup to the total cervix and all. And contraindications, these are very important for you, where not to use a diaphragm. So a patient with prolapse, because prolapse will not maintain the diaphragm. Once you put the diaphragm in, even in cystocele, rectocele, once the patient coughs, the diaphragm will be out. Okay, so never use a diaphragm in such a conditions. Even in any fistulas, rectovaginal or vesicovaginal fistulas also. So those fistulas and all, what they are going to communicate with each other, rectovaginal or vesicovaginal. So there will be, instead of this, there will be urine collection and all. So never use it even in fistulas. A patient with recurrent urinary tract infection, why it is going to damage the bladder, okay, and still going to increase the infection if the patient is having recurrent urinary tract. So it is also one of the contraindications. And allergy. So if the patient is allergy, anyway we are not going to use it. So remember these 4 points. What are all the contraindications for use of diaphragm? And very important thing is we have to remove that, or else if we leave it for a longer time, it is going to cause toxic shock syndrome. It is due to which organism? Staphylococcus. So it is going to cause toxic shock syndrome. Remember, diaphragms you need to remember, you should not keep it for a longer duration. It is going to cause TSS. And the failure rate for Dutch cap is 4 to 6 per 100 women years. Now answer this question. Where is this question? UTI you should not use. Prolapse you should not use. Next. A or D? A or D? We will see. I will tell you some more contraindications, then you can answer. So we have finished now Dutch cap or diaphragm. Now we are entering into the cervical cap. Cervical cap is nothing but same like a Dutch cap, but Dutch cap it is very big thing. Whereas cervical cap it will cover only the cervix. That is called as cervical cap. And especially if the cervix is very long cervix, it can fit very easily. So we prefer a cervical cap in these conditions. And prolapse of uterus. Prolapse of uterus we have told we can't use the Dutch cap or diaphragm. So in such a conditions we can go for cervical cap because we are putting it in the cervix and only to the cervical part. But very important thing is a patient with any cervicitis or erosion or chronic ulcer. So never use this cervical cap. It is going to still irritate. Finally sometimes a patient can land even in cervical metaplasias and all. So in such a cases never use it. So this is the cervical cap. Here we can see it is sitting only, occupying the only cervix. Whereas diaphragm cap it will cover, the Dutch cap will cover entire this part. Whereas cervical cap it is covering only to the cervix. Next, the other name is Duman's cap. So what is the other cap? So what are all the various female methods. So we can even the same, it is also the same, something like a cap which is preventing, cup shaped, same thing. But vault of vagina, it fits well into, vault means beneath the just cervix. So it fits well into the vault of vagina so that it can enclose totally the cervix. So this is the diaphragm. So it is covered totally. This is the diaphragm. Here it is very good picture. This is the cervical cap. It is covering only the cervix. Is it clear? So there are also various methods, that is fem cap, Lea shield. What is this fem shield? It is nothing but a female condom, also known as femidom and all. Here you see, so it is appearing like a male condom but very long and it is very good. Why? Because it is covering entire area. I will tell you how this female condom is very advantageous when compared with male condom. So it is a loose fitting, normally very long, 15 to 17 centimeters. Here we can see this white thing. This entire white thing is the femicondom. So there are various bits on this female condom, femidom. So fem shield, coming to femidom, it is very long thing made up of polyurethane. Which else is polyurethane? Condom, male condom also same polyurethane. It is pre-lubricated. It has got a combined features of both. It works as a condom at the same time as a diaphragm. Why? Because it is covering entire vagina, cervix and entire genitalia. Why? Because this is useful especially in the case of HIV patients and all. So we have discussed already spermicidal jellies, these cups, once you remove put, it can cause irritation, ulceration and can further increase the chances of HIV. Whereas it is very highly protective, especially against AIDS patients, because it is covering totally from the cervix to the outside vagina. Once you put the condom inside, and the slippage is also very low rate. So chances of contraceptive success is very high. And one more thing is, it can be removed immediately after the intercourse. So this is the fem shield, female condom. We call it as female condom. So this is the applicator, this is the condom. We put it with the applicator, so the condom remains inside. And it is very costly, that's why it's not much used. Advantages is, this was asked for you. So it is coital independent. So even before the sexual act, she can wear it. And it does not slip off easily as like a male condom. And the failure rate, that's why the failure rate is very low. And we can use very happily in a case of HIV patients. And whatever the thing, it is very stronger than a normal condom. So the breakage, the slippage and all are less. And even during the peripheral period and all also we can use it, this method. Whereas these caps, diaphragms and all, you can't put it because the patient will be bleeding in the peripheral period. If you put it, it causes infection and all. The blood's collected in the caps. Failure rate. The failure rate is also, when compared with that, it is a bit less, 5 to 15 per 100 women years. The important thing is, it is a bit costly and it is not reusable. Once after the coitus, you have to remove that. Today contains what? Contraceptive. Today tablet. Today contains all of the above. Today can contain octoroxyl, menfenol. Huh? Today contains nanoxynol 9. It is a vaginal sponge along with a jelly. So it contains only nanoxyl 9. What are these octoroxyl and menfenol? Spermicidal agents. So remember, these three are spermicidal, but today contains only nanoxyl 9. Coming to today, what is this today? So it is nothing but a sponge, but a typical sponge which contains a spermicidal agent, that is nanoxyl 9, and it remains effective for 24 hours. Once you put it, it is 24 hours, but it can cause even toxic shock syndrome. You have to remove after 24 hours. If you are going to keep it like this, it is any diaphragm or any caps. If you are going to leave it like this, they are going to cause toxic shock syndrome, and these are very expensive. Today, along with the spermicidal agent, it is very expensive, so we don't much use it. But remember that today contains nanoxyl 9. So we have finished barrier methods. Is it clear? Now we are going to higher step. Finished natural methods, finished barrier methods, going for the intrauterine devices. So what are all these intrauterine contraceptive devices? What are all the various things you know? How many types are there? IUCDs. IUCDs, how many types are there? Hormonal. Huh? What is other? One is hormonal. Next is? Next is, tell me correct. What is other than hormonal? What is next thing? Okay, copper. Which causes ectopic pregnancy? Higher rate of ectopic pregnancy, hormonal or copper? Why? Why? Yeah, good, very good. Progesterone. Why? Why ectopic? You are very correct. It was asked question for you. Progesterone impregnated intrauterine devices are going to cause ectopic pregnancy when compared with coppers. Why? Yeah, very good. Progesterone. What the main action of progesterone anywhere is, it is going to decrease the motility of any structure. So once you put this progesterone devices, is it going to decrease the motility of the tube. So the ectopic pregnancy rates are very high with progesterone. We have discussed this point in ectopic pregnancy. So coming to IUDs. So what is the, when do you advise IUCD to the patient? For all the preferable patients. Suppose an young married, she wants a contraceptive. So can you give IUCD? Then which is the best? Which patient is best? Why you should not give IUCD in young unmarried? So they doesn't want kid for something like 3 years. Okay, very good. Risk of infections is very high with IUCD. So we are not going to give. Then which? Yeah, okay, ectopic. Then which patient you want to give this IUCD? Which patient you want to give IUCD? You want a good success rate, but in which patient you want to give? So for IUCD, this was a all India question for you. So whenever you want to advise an IUCD, the best thing is she should have at least one child. Okay. So suppose patient we have done normal delivery or cesarean section, whatever the delivery or whatever the section. So she doesn't want the child immediately after 3 years, 5 years, whatever may be. So now this is the best option among all other options. The best option for a patient is IUCD, intrauterine contraceptive device. Okay. So this is the time. Minimum one child should be there for a patient to advise for. So if you advise it in young married and even though not one child, chances of adhesions, infections and all is very high. So you don't want to advise this in a young married female. So coming to intraceptive devices. What does this what are all the types? Copper and hormonal. So previously before copper what was there? Lippis loop. So there are even before copper there was something called as Lippis loop and all. So what does this normally? And one more, which IUCD has got longest thing? And what is that? Which IUCD? Suppose a patient doesn't want to become pregnant for many duration. So which IUCD has got longest thing? Longest protective effect. Which IUCD? Novartis for how many years? It is one more has got highest. It was frequently asked question for you. Very good. It is copper 380A for how many years? 10 years. Yeah, Reshma, Rishi. Yeah, correct. It is copper 380A for 10 years. Remember this. Copper 380A is the one very long acting. So most of the my patients I'll give copper 380A because it is the longest acting for 10 years. So whenever either they want 5, 6, 7, they can use it for many days, how many years they want. Once you remove that IUCD, within 6 months most of them they become once again they can conceive. So the longest is for copper, which has got copper 375 has got how many? 375 for how many years? 380A is 10 years. 375A is for no 7 years. In between there is nothing. Either 5, 10 or less than that. 3, 1, 3, 5, 10 years. Okay. 375 is for 5 years. This was asked. Everything is asked for you. No, it is all in your notes. Don't write. It is in your notes. If you read next in the next things, it will come. So 375A is for 5 years. Remember that. Progesterone is for how many years? 1 year. Progesterone will work only for 1 year. Recently, I got a patient. Day before yesterday, she called me. I have delivered her by cesarean section. Doctor, I want a contraceptive. You told me to come back. So I am coming back. But I told her, okay, buy copper tea and come while you are coming. What's the, doctor, I am allergic to all metals. So now what is the other alternative? What is the other alternative? She is allergic to copper. Hormonal. Our hormonal is either progesterone or our second hormonal is levonorgestrel IUDs. Third thing is, what is that levonorgestrel IUD otherwise called as? Mirena. Very good. It is Mirena. So it is otherwise called as Mirena. So progesterone can advise in that patient. She wants contraception for 5 years, but she is allergic to metals. So progesterone it works only for 1 year. Even if I put it, I have to replace every year. So the other alternative hormonal what I have is Mirena. Okay, I can go for Mirena. So coming to COP, we'll start from the basics. Okay, we'll discuss everything. It will come. So it is an effective, very good effective method and reversible. So once you remove it, within 6 months the patient will get once again the increased chances of fertility. And it is a long term method. Why we prefer this patient method is it is a long term. Which is long term? Which thing? Which copper? How many years? Yes, very good. So it and it does not require replacement for long period. So once you give the there is suppose you have put 380A, there is no need for ask the patient like don't ask the patient to come every year or everything. So she can wait nicely for 3 years, 5 years, 10 years, how many years she want. It is a yarn. It is made up of commonly made up of polyethylene. Polyurethane is female and male condoms. Now write this point. So it is there in your books. Underline this. So IUCDs comes under polyethylene. They are made up of polyethylene. This was asked for you. Condoms are made up of A polyurethane, B polyethylene. Okay. And important thing is it is made up of barium sulfate. Why it is impregnated with barium sulfate is it is radio opaque. Once the IUCD is missed. Yesterday patient has come. Doctor, I am not able to feel my threads whatever the IUCD. So we will ask the patient to check for the threads. So we don't know either it has come out or either it has gone inside or somewhere like that. So in such a cases how to know the missed IUCD. So normally if we do any scan or any X-ray under this radio opaque material is barium sulfate which is impregnated on it, we can see wherever the position of the IUCD is. So that is the main advantage. This barium sulfate is not going to cause any contraceptive effect. Is it clear? Barium sulfate is only just to see it. Whenever the IUCD is there in position or not, we can see it because of this barium sulfate. Coming to timing. So when, without seeing the slide, look at me. Now answer. A patient delivered. So when do you want to put her? In normal delivery. IUCD. Normal delivery patient when will you advise? So I'll tell the patient like you have to put an IUCD. So the patient, yes doctor, I am very much interested. So when will you ask the patient to come back in a normal delivery for IUCD? Weeks, tell me in weeks or months, whatever. So in a case of delivery 6 weeks after the normal delivery. Whereas in a cesarean section, we can wait until 3 months after cesarean section. But remember, the best time is 6 weeks. Okay, it is not 6 months, it is 6 weeks. 6 weeks after the delivery, we need to advise. Suppose I have done MTP. She said, I don't want this pregnancy, I want to wait for few more months. So after MTP, when will you advise the patient? You have done MTP or DNC. It is something like anomalous baby. I don't want her to conceive immediately. Yes or no? Suppose a baby with anomalous, I want to put her on folic acid as a prevention for 3 to 4 months. So when will you ask the patient to come back? Post MTP, you have done today MTP, you have delivered, removed the abnormal fetus. So when will you want to put that IUCD? So post MTP and DNC, we can put it immediately. After MTP and DNC, we can put it immediately. So normally a patient, so nothing, I mean she is not delivered or nothing. Now she suddenly recognized, she wants to shift from one method to other methods. She was taking previously OC pills. Now she felt like she is not, because regular taking of pills is very important in a case of OC pills and all. So she came to me, doctor, I can't take regularly, I want to go for an alternative method. So I told her, go for IUCD. So in such a case, when do you want to put? Already the child is something like 2 to 3 years, but she wants contraception for 3 more years. Not immediately delivered, not immediately cesarean. So she has shifted from one method to other method. In such a case, when do you advise? When do you advise? Normally, when do you put? Suppose a patient is post-menstrual, it's already 6 weeks after delivery. So 6 weeks after delivery, when do you advise? Out of 30 days, we can put whenever you want, or there are any specific periods? Or just before ovulation, after ovulation, when do you want to give an IUCD? Why? Why only on 5th day? Why not do just before ovulation? Why not 10th day, 15th day? Why not after ovulation? So it is very good. So all, Why as soon as her periods? So first thing is, after periods indicates that there is no pregnancy. So if you doesn't know the pregnancy, suppose in between ovulation you have put, suppose on 14th day you asked, or 12th day, or 16th day, or 18th day you asked, she might be pregnant inside, you have put an IUCD without knowingly, it will cause severe abortion or infection, okay? So always ask the patient to come immediately after the periods. That is the first important reason. You are sure that the patient is not pregnant, okay? The second thing why you put on that day is, the os will be open, okay? The chances of pain and expulsion are very less during that days. You can put it very easily during that period because the os is open during menstrual cycle. So always post-menstrually, a patient, suppose she called me around 2 days back, it was her something like 13th day. I asked her, complete your periods, then come on 4th day or 3rd day. Once you finish off your periods, then come, then I will give IUCD for you. So always any patient, advise the patient to come post-menstrually. Is it clear why only post-menstrually? Good. That's what it is. People are following that, but for your exam purpose, always remember 6 weeks. Most of the times, if you forgive why 6 months is preferred is in normal and cesarean or delivery, if you maintain a good breastfeeding method, the chances of failure rate is very low. It was how much? With breastfeeding? 0.5 to 1%. That's what I tell you. Breastfeeding, regular breastfeeding every 4th hourly. If you follow it correctly, no need to go for any other method. But nowadays the patients are not following it. So that's why any case we tell 6 weeks. That's what you remember, 6 weeks for your exam purpose. Yes, for your exam purpose it is 6 weeks. Yeah, ideal candidate for copper incision are all except D is means normal periods. ABCD answer is Shan, your right answer is C. So a patient, whenever you put IUCD, it is very important for first every month she should check her tail. I will tell you what are all the tails. So beneath the IUDs there are some threads. It is made up of nylon threads. Always the patient should check the tails. If she doesn't check the tails, what is going to happen? Suppose it is perforated, it will go inside the abdomen, or it might have expelled. Sometimes she doesn't know that it has even expelled also. So every time immediately after the periods you should check it. Why immediately after the period? Because during the periods the os will be open. So once the os opens, automatically the device can come out. So every time during her periods you should check it immediately after the periods for every cycle. So she should be willing to check the IUD tail, and minimum, previously we know, for IUCD she should have minimum 1 child and she should have normal periods. Has history of ectopic. In ectopic you want to put it once again, it still increases the chances of ectopic pregnancy. So out of 4 options, this is the least. So are all except this. Coming to these are biological inert devices. Even before copper teas they are called. So these include Lippis loop, safety coil, mahua and water ring. So don't, once the question they ask you, don't think something strange. These are all nothing but biological inert devices. Previously they used to use this, and they can be left for several years inside and without any causing, but nowadays we are not going for these inert devices. Coming to next generation, it is copper carrying devices. What is this copper carrying devices? Nothing but there is a, here you can see, this is the vertical stem, this is transverse stem, and this is the nylon threads, what I have told you. So they should check this nylon threads every time. So this copper T, I am going to insert it inside the uterine cavity. So it is nothing but the, you can see some wiring like this, okay. That is nothing but copper. It has got a surface area of around 200 to 250 mm wrapped around the vertical stem. Okay, we have seen. That is the vertical frame. Around the vertical frame, it is rounded, wrapped around. So there are, there are various steps coming to T200, copper 7, multi-load, whatever may be. So all other copper devices, they work for 3 years. Remember that. Okay. All other copper devices, they work for 3 years. Copper 375 is for 380A is for this, you need to remember. So how much copper it is going to release every day? So every day it is going to release 50 micrograms of copper is going to get released in the uterus every day. So copper 380A, otherwise called as Paragard. One more name for it is Paragard. Remember this name. It's otherwise called as Paragard. Has a lifespan of 10 years. And Novate, remember important point regarding the Novate is, along with copper it has got silver. So this was asked for you. Novate contains what? Copper only, copper with silver, copper with aluminium, copper with platinum, something like that. So the answer is Novate contains what? Silver and copper. So both are there. Lifespan of Novate is 5 years. Which has got 5 years? The mechanism of action we'll see. First coming this, we'll see the mechanism of action. So most copper devices, it will work for 3 years. 380A for 10, Nova for 1, progesterone for 1 year. Progesterone. So progesterone, it is nothing but the same simple T-shaped, same like what we have seen like copper T. It contains 38 mg of progesterone, releases 65. Remember these values, how much it contains, how much it releases. This was asked for you. So it contains 38 and 65. That copper T releases how much? So when compared with copper and hormonal, the progesterone's important thing is, there are various mechanism of action. I will tell you in chart, I will compare you. But progesterone's extra advantage when compared with copper is, they form a thick mucus plug. What is the main role of progesterone? We have previously discussed. The progesterone thick mucus plug which further prevents. So when compared with copper, it has got an additional advantage. The important thing is, it forms a thick plug of mucus at the cervical os which prevents the penetration of the sperms. And moreover, why we have shifted from copper, menstrual problems like menorrhagia and dysmenorrhea are more seen with copper T. But when compared with hormonal, they are less seen. So a patient never assume that. When we come to complications, I will discuss. So whenever you put an intrauterine device, there are chances of expulsions, bleeding. This a patient has come yesterday. I have put in January the copper T. So she came, doctor, in between for 2 cycles I had mild spotting, or just before the periods I was used to get spotting or excess bleeding. But now she is totally comfortable. So the important thing is, they can be excess bleeding or decreased bleeding, whatever abnormality can be there with intrauterine devices. But you can, so suppose a patient has come like this, don't remove the copper T. So you can wait for 6 months, whatever the irregularities are there, they'll set by itself. Now the patient is totally comfortable and without any complaints. Okay. So the copper, whatever the copper T devices, they have got this menorrhagia and dysmenorrhea. But this hormonal, why we have proceeded to this next generation is the side effects with hormonal are very less. But why still we are preferring copper T is the hormonal Mirena is very costly. It is around 7,000 and it is not available and it's a very thick one also. So we need local anesthesia to put the Mirena inside. And Mirena is very good if we can use it. But Mirena is very thick, it needs local anesthesia and it's very costly and it is not available. Patients are not affordable. Whereas copper T is supplied free of cost by government. Coming to hormonal progesterone, it will work only for 1 year. That's why we are preferring copper devices. And hormonal we know, progesterone we have to replace how many years? Yearly, every once a year. So now we will see the mechanism of action. The levonorgestrel, they have asked which of the following is not a mechanism of action of IUDs. Coming to mechanism of action, levonorgestrel releasing IUD, otherwise called as Mirena. It inhibits fertilization, we know both of these are going to inhibit copper releasing and this, and thicken cervical mucosa, whereas a copper they doesn't have a thickening mucus. Remember this point, thickening mucus is seen only with progesterone. Here it inhibits even sperm function, and I will tell you in detail how it is, how it has got an endometrium has got even the phagocytic function. This whatever the copper, the main thing how it is going to act is, it is going to cause nothing but an inflammatory process. Whatever the any abnormal thing is there in your body, what is going to do? It causes an inflammatory. So inflammatory, what is going to happen? The macrophages are released. These macrophages are going to engulf the sperm once it is formed immediately. So that is the main mechanism of action of these copper devices. And it okay, in the next slide we can see. So this is the thing. It prevents the ascent of sperms by acting as a foreign body. First thing, which of the following is a mechanism of action? Copper devices. Next, they alters even the enzymatic activity of the uterus. That's what I discussed. The inflammatory process, the macrophages, they're going to come and kill the sperm. Inflammatory changes, macrophages consume sperms and prevent fertilization. This is seen for both copper and for hormonal. But hormonal has an extra advantage of, except progesterone should be changed for Is it clear? This was all India questions and AIMS questions. So composition is copper and silver, not aluminum and all. So coming to Mirena, we'll stop with this. We'll discuss tomorrow. We'll go for quiz. It's around 20 minutes.